everyone. Welcome you all for the IPNA Endorsed Webmaster Series 2020. Now we have entered into webinar 22 and it's a pleasure in welcoming you all. And so today we have three eminent speakers, Dr. Susan, Dr. Jayati and Dr. Sasidaran. So Dr. Susan will be moderating the session for today. Dr. Susan is a pediatric trained from KEM Hospital and St. GS Medical College, Mumbai. She has got a twin degree like GM and DNB nephrology from Government Medical College of Trivandrum, and she's a professor and head of Department of Pediatric Nephrology at SAT Medical Hospital and Government Medical College, Trivandrum, and she's also a honorary consultant pediatric nephrologist at Sri Chitra Institute of Sciences and Technology. Her special academic interest is towards pediatric CKD and dialysis. She has got n number of publications in national and international forum. She is also a member draft committee of ISPN guidelines. And adding on to many awards and honors, she's a first rank holder, probably in all her undergraduation years, and best outgoing student from Kottayam Medical College in the year 1991. She is also a recipient of Ambadi Bhaskara Menon Gold Medal in the year 1991. And she has completed her fellowship in ISN in 2012, and she is also trained at Cincinnati Children's Hospital 2012. Over to Dr. Susan.
Thank you, Dr. Kalaivani, for those nice introductory words. And ladies and gentlemen, colleagues and friends, let me first of all congratulate Namalwar, Dr. Kalaivani, and the great pediatric nephrology team at Mehta's Hospital for this series of international webinars sponsored by IPNA. It had been a sumptuous academic feast all through these months, starting soon after we all became virtual with the COVID pandemic. Today, we have got two hot topics to be discussed, and two eminent speakers are there with us to discuss these topics. All of us know that renal diseases due to tropical infection is an intriguing problem with a myriad of manifestations and consequences. Geographically, the tropical region is actually situated on either side of the equator between the Tropic of Cancer and the Tropic of Capricorn, and the strip of the land comprises 1/3 of the Earth's landmass, home to majority of world's population, animal and plant biodiversity, adding to the complex interactions and subsequent infections and problems. Prevailing poor social and economic circumstances translate to increased susceptibility to infection and poor access to healthcare services. Acute kidney injury in tropics is mostly community acquired and affects the young population, mostly children, adolescents, and young adults. We know that the myriad of problems that we have to face as clinicians, starting from malaria, leptospirosis, then gastroenteritis, dengue fever, hemorrhagic fevers, and scrub typhus, gastroenteritis, toxins and envenomations, the list is very long. To discuss this topic with lot of public health impact in a developing country like ours, we have an eminent pediatric nephrologist from Calcutta. She is a great academician with a long 20-year experience in pediatric nephrology, Dr. Jayati Sengupta. She is a consultant pediatric nephrologist at AMRI Hospital and Institute of Child Health, Calcutta. Over to you, Jayati, for this wonderful topic.
Thank you, Dr. Susan. Thank you, Dr. Susan and Dr. Kalaivani, for Dr. Susan for this wonderful introduction, and Dr. Kalaivani and the Mehta Children's Hospital for this sumptuous feast of academic activities virtual, which we are really enjoying, and it's become almost like a timetable. I mean, before we know that it's Wednesday, from the morning onwards, we look forward to having an academics in the evening. So, Dr. Susan, I shall get on to my slides. Dr. Susan has given a very brief, good introduction about the tropics, and as she has already said, that this just between 23 degrees north and south of the equator, we have 1/3 of the land, but 40% of the world population, a place, a whole area which has very high ambient temperatures, heavy rains, and sometimes even arid deserts. And because of this huge biodiversity in climatic conditions, in ethnicity, in the socio-economic and developmental status, there has been seen an increased growth and survival of pathogenic microbes and parasites, vermins, all kinds of infections caused by these flourish. Adding to these problems, we have countries which have low socioeconomic statuses. I mean, a huge population living below the poverty line with poor quality of sanitation, contaminated water, which again increase the chances of infection. And most of the countries here are what is known as by WHO as the low medium income countries and with very limited healthcare facilities. So out of around more than 40% of the world's population, around 1 billion people living in the tropics get infected with these tropical infections every year, causing more than 170,000 deaths. And not only they are a major cause of morbidity and mortality, they are a major public health problem because the diagnosis is often late, the long-term outcomes are often not studied, and there's a huge limitation of underreporting, and therefore we have very scattered evidence of many diseases. So our agenda today is to take you through these common tropical infections which affect the kidney, their pathophysiology in brief, and a clinical spectrum of the kidney involvement, and to just have a look into the novel biomarkers which are coming up and their probable role in tackling these infections. Now, the kidney involvement in tropical infections can be acute or chronic, depending on the microorganisms. You can have, like you have in dengue, or you have in tuberculosis, or it may be epidemic or endemic, again, depending on the type of organisms which are prevalent in that area. All kinds of microbes like virus, bacteria, mycobacteria, fungus, protozoa have all been implicated in these kidney diseases. So if we see the tropical nephropathies, and we can just divide them very broadly into two halves. One is the infective the varieties, which is caused mainly by the bacterial, the viral, parasitic, and other infections, of which the prototypes, as Dr. Susan mentioned, are the leishmaniasis, dengue, leprosy, schistosomiasis, malaria, leptospirosis, etc. And we have what are known as the toxin-induced nephropathies, some which can be of animal origin, like snake bites, scorpion bites, bee stings, or maybe of plant origin, like several types of mushrooms and then called beans. We shall not deal too much with the toxic ones. We shall be mainly concentrating on the infective causes today. Okay, now the infections by these infections, these tropical infections, basically, their action on the kidney can be because of two reasons. One, they can be a direct invasion of the kidney, the epithelial cells, which is common in the bacterial infections. Or there can be an indirect invasion by an immune-mediated mechanism by formation of immune complexes. So the first mechanism, that is the direct invasion. What happens here? There is a direct cytopathic injury, most commonly seen in the pathogenic infections like tuberculosis or leptospirosis. What happens here is there are the toxins which are produced by the kidney. For example, in the uropathogenic E. coli, the alpha hemolysin, which is produced by the organism, it has a direct effect on the renal epithelial cells, and the granulocyte macrophage colony stimulating factor, which is secreted by the cells, that is upregulated, and this causes a lot of macrophage accumulation in the kidney, which leads to kidney damage. As you can see here, there's a lot of cellular infiltration in the kidney caused by a direct cytopathic effect of the toxin. Second mechanism would be the immune mechanisms, in which there may be immune complex formations either in the circulation, which pass through the kidney and get deposited inside the kidney, or there may be in situ formation of immune complexes in the kidney itself. And many of the viral glomerulonephritis can cause this. Now, what happens here? As you all know about the immune complex mediated diseases, the antigen-antibody complexes which form and there are a lot of antibodies formed by the B cells, the T cells, the plasma cells which form antibodies, and the complexes are formed, and these can either circulate through the blood and get deposited in the kidney, or they can directly and on the kidney, specifically on a part of the kidney like the basement membrane or the endothelium or the subendothelium or the epithelium, they can cause deposition followed by renal damage. And the renal damage, as you can see here, there can be, according to the type, the place where they are deposited, the immune complexes, it can give rise to different types of glomerulonephritis. Like you can have subepithelial immune deposits, which can cause membranous glomerulopathy, or you can have subendothelial deposits, which can cause a lot of proteinuria, hematuria, mesangia, membranoproliferative glomerulonephritis. There can be also if affection of the mesangium and immune complexes deposited there. The third mechanism is as a part of sepsis-related multi-organ failure. That is the systemic inflammatory response syndrome, in which there are a lot of cytokine expression, hemodynamic disturbances, hemolysis, rhabdomyolysis, hepatorenal syndrome, all giving rise to a lot of activated oxidative stress factors, causing a lot of hemolysis, and they have a direct effect. This causes an effect on the kidney. There's hypoxia, there's renal ischemia, and followed by endothelial cell damage. Last but not the least are the nephrotoxic effects of certain antimicrobials, which can be used for treatment of these infections. This is very common in leprosy. So as we had discussed in sepsis, because of the toxins and because of the ischemic insult, there are a lot of hemodynamic changes. There's hypoperfusion, there's ischemia, reperfusion, microthrombi, which all lead to hypoxia, oxidative stress, and endothelial dysfunction, leading to renal cell injury. They may be sublethal or lethal, causing cell loss and acute tubular necrosis and acute kidney injury. Now, if we talk of the tropical infections, as we had said, that they can be divided into bacterial infections, they can be viral infections, they can be protozoa. Let's start with one of them, the bacterial infections. Obviously, the causative organism, the severity of infection, the individual susceptibility, and the host response to the infection is very important to decide the nephropathy or the clinical, the way the kidney will be affected. The salmonellosis, shigellosis, leptospirosis, these kind of infection, they usually cause acute symptoms. And mycobacteria, like causing tuberculosis and leprosy, affecting the kidney, usually cause chronic infections. So the common clinical presentations are in acute infections, are fever with jaundice. So if a patient has fever with jaundice, with thrombocytopenia, transaminitis, it is possible to be leptospirosis. If the patient has, say, severe myalgia with thrombocytopenia, hepatopathy, it may be dengue. Fever with maculopapular rash, eschars, maybe scrub typhus. Fever with splenomegaly, thrombocytopenia can be malaria, and so on and so forth. Fever with diarrhea can be viral or bacterial gastroenteritis. So these are the common clinical presentations of the tropical infections caused by bacteria. Now, if you see the kidney involvement, it can vary from just asymptomatic proteinuria, often missed, to more abnormal urinary sediments like hematuria, to almost fatal acute renal failure. Now, each bacteria can have different types of presentations. For example, say salmonellosis. Salmonellosis not only can cause proteinuria and hematuria, but it can also cause sometimes acute renal failure. But more or less, each bacteria has a very typical, usually have a typical presentation. For example, leptospirosis, they can cause not only glomerulopathy causing proteinuria, but they can also cause acute renal failure. And they can also cause jaundice. So these are the symptoms of the kidney symptoms, and these are the other infective symptoms which can be seen in these patients. For example, if you see tuberculosis and leprosy, there it is more of a proteinuria and less of chronic acute symptoms. So according to the type of bacteria, the kidney symptoms will vary. So and then depending on where the bacteria is affecting the kidney, whether it is the glomerular involvement or whether it is the microvascular compartment which is getting involved or the tubular interstitium, the kidney will have different nephropathies. So you can not only have glomerulopathies like nephrotic syndrome or nephritic nephrotic syndrome or interstitial nephritis or an RPGN, but you can also have an acute kidney injury. So they can manifest in several ways. For example, you see the different bacteria here. If you see, the glomerulopathy is varied. So salmonellosis may cause a mesangial proliferative glomerulonephritis, whereas a leptospirosis is more likely to cause an acute tubular necrosis or an acute interstitial nephritis. So according to the type of bacteria, the nephropathy can also vary, and where the immune complexes are getting deposited, the nephropathy will vary. The ones which are more chronic will have mainly membranous nephropathy, and the ones which are acute or subacute usually cause membranous proliferative glomerulonephritis. If we come to the viral infections, again, their injury, the kidney injury by the viral infections can be because of cytopathic effects, immune complex mediated glomerulonephritis, and vasculitis. The common viruses like hepatitis B, C, E, HIV, dengue can induce glomerulopathy, but dengue can cause more of acute tubular necrosis and acute kidney injury. And the viruses like parvovirus, Epstein-Barr virus, cytomegalovirus, they can cause sometimes very severe injury, causing collapsing FSGS. So if we see the nephropathies by the different viruses, we can see that some viruses can cause different type of presentations. For example, hepatitis B. It can present acutely as acute tubular necrosis or diffuse proliferative glomerulonephritis. It can again present subacutely as polyarthritis nodosa, or again, it can present as a chronic membranous nephropathy or a type 1 mesangial proliferative glomerulonephritis, or even an IgA nephropathy. But whereas, say, dengue would be most of the time presenting as acute tubular necrosis and probably acute, sometimes as a mesangial proliferative glomerulonephritis, but it will be mainly an acute presentation. So some viruses can present, the same virus can present differently, whereas some viruses will have a pattern of presentation, a very typical pattern of presentation. If we see the parasitic infections, which are huge numbers like malaria, leishmaniasis, very typical to the tropics, filariasis, schistosomiasis, not all are present so much in our country, but these three are pretty common in our country. These also, these infections also can have, they can cause coagulopathy, they can cause mesangial cell damage, and they can also deposit circulating immune complexes in the subepithelial areas, the mesangial damage causing in the mesangium, obviously, and the coagulopathy in the subendothelial areas. All of them together can lead to membranous proliferative glomerulonephritis. They can cause mesangial proliferative nephritis or membranous nephrotic type of nephrotic syndrome. So if we see, in a nutshell, we can say that these tropical infections mainly cause two types of kidney injury. One is an acute kidney injury, one is a glomerulonephritic type of kidney injury, which are usually subacute. Sometimes they may be rapidly progressing and can lead to an acute injury. So, and both of these can ultimately lead to chronic kidney diseases. So let's see the glomerular involvement in these infections. The prototype, as we all know, is the post-infectious glomerulonephritis, in which there is an immune complex mediated glomerulonephritis. The presentation can be very asymptomatic. If it is a post-streptococcal nephritis, it's usually with acute nephritic type of illness with hypertension, sometimes even causing rapidly progressive glomerulonephritis. But in some other infections, it can be even be it can go totally unnoticed. It may be an asymptomatic urinary abnormalities with mild proteinuria. Many of these not only we have these immune complexes deposited, but over the period of time we are getting some novel biomarkers like the PLAD, the plasmin, the reactive antigens which are deposited in the subendothelial areas, which can also give a clue to this infection-related glomerulonephritis. In tuberculosis, the glomerular involvement is mainly in the form of amyloidosis. How the amyloids are formed is not yet very well understood, but a new diagnostic approach using the amyloid protein scintigraphy has been found to be great help in evaluating the type and the amount of amyloid deposited, because it has been seen that if the amyloid, if it is detected early, then by the curing tuberculosis, the amyloidosis can also get cured. In leprosy, the funny part is that clinically only 2% of patients will have glomerulonephritis. But renal biopsies have shown in different studies that 13 to 71% of patients can get glomerulonephritis. And many of these patients may be initially missed, and they can end up becoming chronic kidney disease patients. The common glomerular lesions are mesangial-proliferative, diffuse proliferative, membranoproliferative, and precentric. Sometimes these patients can also have microscopic polyarthritis nodosa, as we shall see in this slide, that the patients of leprosy who have a lot of rash, the erythema nodosum type of rash, they have a lot of reactional states, they usually have vasculitis, and they can cause polyarthritis nodosa. Apart from this, there may be direct renal injury by the bacillus with granuloma formation and cause tubular interstitial lesions. And with prolonged, and as we had discussed earlier, because of nephrotoxic drugs also, we can have tubular interstitial nephritis. And long-term patients can have renal amyloidosis. Filariasis, though we see less often now, especially Wucheria bancrofti, which is common in our country and in Southeast Asia, Onchocerca volvulus and Loa Loa, commoner in Africa and South America. Not seen here. And the renal involvement is mainly subacute, and it's usually with nephrotic syndrome. Very rarely you can get an acute presentation. Again, most of these are membranous and mesangial capillary type. Schistosomiasis again is not common in our country. Only a few percent, only 0.75% they develop glomerulopathy. Most of them have subclinical renal disease. And these have a slightly more acute presentation. They have around nephritic syndrome in 60% of patients with a non-nephrotic proteinuria. Sometimes, if it is, they can present as the renal biopsies we do show a membranoproliferative glomerulonephritis. And there's a lot of immune complexes deposited in the mesangium, which can be IgG, IgM, or C3. Now let's come to Kala-Azar. Now Kala-Azar was a very common infection and very endemic in certain states of our country, which has significantly come down over the years because of the availability of medicines and improved sanitation. Patients usually present with severe anemia, leukopenia, hepatosplenomegaly, thrombocytopenia, and increased gamma globulin levels. They can have either, most of the time they have moderate proteinuria, but some patients can have hematuria and WBCs in the urine. But what is more characteristic is these patients can have a lot of tubular problems and leading to defects in the urinary concentration and acidification. So you have a lot of dyselectrolytemia and electrolyte disorders like hyponatremia, hypokalemia. The immune complexes which are formed because of the B-cell humoral immune activity, the antibodies formed, which are usually associated with the symptoms of nephropathy that we see in Kala-Azar, because the antibodies are produced in response to the immune complexes and they are deposited in the glomerulus, inducing a local inflammatory reaction. Now let's come to the viruses. The hepatitis B virus, the most common cause of nephropathy that we know, and it can have a huge variety of glomerulonephritis, starting from minimal change nephrotic syndrome to membranous nephropathy to polyarthritis nodosa, even lupus nephritis. So the whole spectrum of nephropathy can be seen in hepatitis virus infections. In children, especially who are chronic carriers of hepatitis B, they only usually show the infection. They can have nephrotic syndrome. Commonest variety is membranous nephropathy. And in contrast to adults, many of the children, the nephropathy resolves spontaneously. Sometimes we also get membranoproliferative and mesangial-proliferative nephritis. Now, if we see this chart, we can see that the HBe antigen, when it combines with the anti-HBe, that is forming of the antigen-antibody complex, these immune complex, they deposit on the glomerular basement membrane, and these usually lead to the membranous nephritis. But if you have the HBsAg, that is the surface antigen, the antigen-antibody complex of hepatitis B surface antigen will cause a mesangial-proliferative, usually a single endothelial deposition, and they can also cause vasculopathy leading to polyarteritis nodosa. Similarly, you can have a type 1 because of the type 3 the immune complex, the reaction, you can have a type 1 type of MPTN. And if there's a direct tissue infection, there can be IgA deposition and also sometimes sclerosis of the glomeruli. The KDIGO recommends that we use a nucleotide like tenofovir, adofovir, or a nucleoside like lamivudine and reverse transcriptase inhibitors for the membranous nephropathy. Lamivudine usually was used to be used commonly as singly before, but it has caused a lot of resistance, so it should be used along with combination. But universal vaccination with hepatitis B is the only and the most effective way of prevention. The other viruses, the glomerulonephritis, usually less of glomerulopathy, more of acute tubular necrosis and more acute kidney injury, so we shall not go into details with them. The dengue virus, for example, can cause a diffuse proliferative glomerulonephritis by direct viral into renal tissue and also by immune complex deposition. And if you have a glomerulonephritis due to dengue, you will be having a lot of proteinuria apart from the hematuria, which will differentiate it from the acute tubular necrosis. And obviously the treatment is supportive, and it has been seen that with the infection getting controlled, the nephropathy also improves. So what is so unique about the tropical acute kidney injury? Just as Dr. Susan had said, that yes, the infections are mainly community acquired rather than hospital acquired infections, which is seen most in the tropics. There are a lot of natural medicines, herbal medicines, which can contribute to nephropathy. The relatively younger age group is seen in children in tropical nephropathy rather than in temperate zones. And because of the gross inadequacy of treatment facilities and then endemic malnutrition and relative hypovolemia because of sweating and high temperatures, it all leads to or exacerbates the acute kidney injury. And we also have a big population having GCPD deficiency where hemolysis is quite common, which obviously adds to the problem. So you can have a whole list of causes which cause acute kidney injury, starting from falciparum malaria, leptospirosis, typhoid, hemorrhagic fevers, diarrhea, plant toxins, animal poisons, chemicals like ethylene glycol, as Dr. Baga was speaking yesterday, as well as some miscellaneous causes like HUS, GCPD deficiency, which can lead to acute kidney injury. We shall not deal with those. We shall only be talking about the common tropical infections which can cause acute kidney injury. Malaria, leptospirosis, dengue, strep typhus, yellow fever. These, I think, are the commonest ones which cause acute kidney injury in our country. And as you can see, most of them, the injury is by causing acute tubular necrosis, sometimes cortical necrosis. There may be thrombotic microangiopathy, and even glomerulonephritis. Leptospirosis can cause vasculitis. So more or less, it is mainly acute tubular necrosis and thrombotic microangiopathy, which is caused by these different infective agents. What happens in dengue? Now, you must have all seen dengue rashes. In dengue, what happens is the neutrophils, which because of the innate immunity, the neutrophils are obviously first activated. they give rise to a lot of reactive oxygen species, which directly lead to tubular cell damage. The lymphocytes, on the other hand, especially the Th1 lymphocytes, they produce pro-inflammatory cytokines, which lead to the inflammatory process of acute kidney injury. And it has been seen a high neutrophil lymphocyte ratio increases the risk of developing acute kidney injury. Sometimes, as Dr. Baga was saying yesterday, that we are seeing more and more cases of thrombotic microangiopathy due to dengue, causing with severe thrombocytopenia and hemolytic anemia. Bilirubin, because we all know that dengue causes hepatopathy, so bilirubin may act as a direct nephrotoxin, and it can promote renal susceptibility to ischemia, which again lead to AKI. And if you have elevated transaminases, very high levels of the transaminases, and along with that you have jaundice, hypoalbuminemia, and a prolonged post-traumatic time, patient is more likely to develop an acute kidney injury. So very seldom we need to do renal biopsies in dengue patients, but there have been studies in which it has been seen, and this renal biopsy is from a 71-year-old patient who had glomerular injury, mainly induced by interleukin 17. But if you see that there is mainly hypertrophy and hyperplasia of the mesangial and the endothelial cells, we don't have an electron microscopic picture here, obviously, and there is focal thickening of the glomerular basement membrane, which is obviously also not very well visible, and there is immune complex deposition in the glomeruli. What happens is yellow fever? Yellow fever is not present in our country, so we don't need to go into much details about this. It is the information about yellow fever is very, very scarce. Usually patients have oliguria, and sometimes they can develop severe yellow fever. They can go on to having acute tubular necrosis. Again, the reason is very obscure. Probably they are because of renal ischemia, intravascular coagulation, shock, and bilirubin-induced tubular toxicity. Hantavirus is also not very common in our country, but hantavirus, the acute kidney injury is mainly because of a direct viral infection of the endothelial cells, causing capillary leakage and intravascular volume depletion, leading to acute kidney injury. Let's come to malaria. What happens in malaria? In malaria, what happens is the malarial parasite, it affects the red blood cells. We know that. Now, these red blood cells, the ones which are infected, these red blood cells have get some knobs on them, and these they become more sticky. So these red blood cells, they now stick to the vascular endothelium, along with the normal red cells. And this is known as cytoadherence. And because of this, there is this causes an inflammatory reaction. This leads to along with that there is hypovolemia, and because of this inflammatory reaction, there is cytokine and nitric oxide production. This leads to arterial vasodilatation, and there is cytopathic hypoxia, leading to decreased ATP synthesis. And as I said, because of the cytoadherence, there is a mechanical obstruction leading to hypoperfusion of the organs, and the kidney is affected. The mortality of malaria can be between 15 to 50%, but the renal lesions have been seen to resolve within 4 to 6 weeks of anti-malarial therapy. In children less than 5 years, AKI due to malaria has a 70% mortality. The renal involvement, as we said, is commonly in falciparum malaria, mainly because of AKI, but in children who have plasmodium infection with Plasmodium malariae, they usually have something known as the quartan malaria, which is more chronic, and they can just present with transient glomerulonephritis and mild non-nephrotic proteinuria. If you do their serum complements, they are usually decreased. So this is a histology of a patient with malaria. As you can see, there is acute tubular necrosis. There are hemosiderin-laden granules in the interstitium, in the tubular interstitium that you can see, and there is deposition of immune complexes. Here there is IgA deposition, and there can also be IgM and other complement deposition. Here there is a lot of eosinophil infiltration of the globuli also. Treatment is obviously with antimalarials, but what is more important for us is that the early initiation of dialysis is very important for malarial acute kidney injury. So even if intermittent hemodialysis or CVVH or CAVH, but even if you don't have access to anything, even a high volume peritoneal dialysis is good enough. But early initiation of dialysis is very important. Hypovolemia should be corrected, and albumin infusion may be used for volume expansion of these patients. They can be also treated with, sometimes they might need plasma exchange and plasmapheresis, especially the erythrocytopheresis, because the erythrocytes become infected with the bacteria. In scrub typhus, the eschar, which is most often than not seen, is sometimes very difficult to diagnose initially, but high fever with multi-organ involvement can also cause renal involvement. Though it is not that common, but if involved, it can present as a septic shock with rhabdomyolysis, vasculitis, and acute interstitial nephritis. Here, there may be a direct invasion of the kidney tissue by the Orienta Sushugamushi. Leptospirosis is quite common. That is a rat bite fever that we know, common in certain parts of our country. Usually, initially, they present with high fever, severe muscle pain, myalgia, and all these things. But some people can go on to having the second phase of the disease, that is a wheel syndrome, which is a more severe form. And these patients can have acute kidney injury. So, because the kidney is one of the main targets of Leptospira. But what is very characteristic about Leptospira infected causing nephropathy is that it is most often non-oliguric and hypokalemic rather than hyperkalemic. So there's a lot of urinary loss from the tubules, leading to hypomagnesemia and hypokalemia. And the main reason is the direct effect of the bacteria on the renal tissue, and this leads to a lot of hypotension. And because of the renal damage, there is hypertension. Along with that, rhabdomyolysis, hyperbilirubinemia, all of these lead to endothelial glycocalyx damage, leading to acute kidney injury. This endothelial, we shall come to the endothelial glycocalyx damage a little later when we talk about the novel biomarkers. Okay, so it is mainly interstitial nephritis, as you can see. We shall be doing injustice if we do not talk about diarrhea and AKI, because diarrhea was, I think, just a few years back, was the commonest cause of AKI needing renal replacement therapy. But over a period of time, with a lot of ORS coming into the picture and much better sanitation and clean drinking water available now, and vaccination with rotaviral vaccines, the infective diarrhea has reduced significantly. And now, but still, we have patients of diarrhea who sometimes can go into acute kidney injury. I think the most important of them to be discussed should be the E. coli, the enterohemorrhagic E. coli, which produces the Shiga toxin. And it basically accounts for almost all the cases of post-diarrheal HUS, which is seen in our country, in the neighborhood countries of Bangladesh, and even in southern Africa. So this is very similar to the 0157 E. coli, which causes HUS. Only thing is, the Shiga toxin by the enterohemorrhagic E. coli the infection is more severe, and the mortality rate is even higher. The another thing which causes vasculitis-induced renal damage is infective endocarditis. But the good part is that with the elimination of the causative organism from the bloodstream, the renal damage also improves. I think no talk should be complete now without one mention of the SARS-CoV-2. Though it is not a tropical infection, it is a pandemic, as we all know. Everybody is getting affected, including us. And here, the injury is mainly by all three mechanisms: direct cytopathic effects, the cytokine storm that we are constantly speaking about, and immune complex mediated injury. We'll have one or two words on the toxins which cause kidney damage, because it's so typically tropical in its whole entirety spectrum. So snakes like vipers, and bees, multiple bee stings, sometimes caterpillars, and these very infective spiders, like Loxosceles spiders, they are common causes of venom-induced AKI. This is just a summary of the different the toxin-induced AKI, the reasons behind them, which can be Russell vipers, which can be these bees, which can be the spiders, the scorpions, and most of the time the renal histology is basically acute tubular necrosis, cortical necrosis. The effects of the venom in the snakes is mainly by hemolysis and rhabdomyolysis, and same with all the other toxins. So most of the toxins cause local injury, they cause hemolysis, they cause rhabdomyolysis, leading to hypertension, hypovolemia, and shock and renal damage. So if you see this slide, this is acute cortical necrosis caused by Russell viper, which is the commonest cause of AKI due to snake bite in our country. And obviously, it depends on the bite size, the victim body size, the more surface area which is exposed, and how fast the patient is seeking medical help. Now, since we have more or less discussed all the different types and the causes of kidney injury in the tropics, let's see if we can, apart from the clinical and the renal histology, the urinary markers, the blood markers, high creatinine, which we commonly normally know of, or anything new which is coming up in the horizon to diagnose these nephropathies. So these novel new biomarkers, which are being talked about in many situations, have also come to in this fora of tropical diseases, in which because these infections obviously have some inflammatory mediators and endothelial biomarkers which are deposited in the kidney, which can be sometimes measured, and they can, if they might give you a clue to the disease severity and the progress. Now, proteinuria, we all know is a hallmark of any kidney disorder, especially of glomerulopathy, and it may be because of the podocyte injury and podocyte loss, and the whole endothelial epithelium and the glomerular basement layer abnormalities. Now, in certain infections, especially as we spoke about in leptospirosis, there is a loss of the glomerular endothelial glycocalyx layer, which is very rich in negatively charged proteoglycans. Now, there is this Syndecan-1, this chemical, which is released in the plasma, which is a biomarker of the endothelial glycocalyx layer. So, if the presence of this will give us a clue that there is definite injury, kidney injury. Apart from that, gamma interferon, CRP, the C-reactive protein, the interleukin 6, 17, they are all associated with renal events, especially in visceral leishmaniasis, in dengue, and in leprosy. These kidney biomarkers like NGAL, like NCP1, that is monocytic chemotactic peptide 1, the vascular endothelial growth factor, the fibroblast growth factor 23, they also provide important information regarding the location and the chronicity of the kidney injury. If we see this slide, we can see that in specific infections, there are specific biomarkers which have been investigated, and their usefulness is being being more evaluated. Like in dengue, the NGAL and the resistin have been found to be high, and this will give us an early indication that there is kidney injury. In leishmaniasis, because of the tubulopathy, the aquaporin 2, the sodium potassium chloride channels, the sodium hydrogen exchanger, all these will give you an idea about the defects in the tubular transport. Similarly, in leptospirosis, as we have said, NGAL, Syndecan-1, these will give an idea about the AKI and the endothelial damage. So also in malaria, and so also in schistosomiasis. So these novel biomarkers will need a much more investigation and research to make them as a protocol for investigations of evaluating kidney disorders in these different tropical infections. So, and here we have another one in which, as we all know, that because of the inflammatory response, ischemia, reperfusion injury, oxidative stress, which is leading to the endothelial cell and the tubular epithelial cell injury, causing abnormality in the glomerular filtration barrier, you can get this the STREM1, which is the soluble triggering receptor, which is expressed on the myeloid cells 1. And so finding STREM1 in the urine will also give us an idea about the immune complex mechanism of the infection which is causing it. So in summarizing, tropical nephrology is no longer a regional issue because this enormous amount of travel and immigration, the world has almost become a global village. And so a health problem in a particular region will have worldwide repercussions. And what is important is these tropical infections can, though they present most of the time acutely, they can have long-term impact on the kidney and they should be investigated. And because they can be a major cause of future of chronic kidney disease in long term. So it's come to the last. Thank you so much. Though we have tropics being the hotbed of infections, but still tropics is not always that bad. We can still have beauty in the tropics.
Thank you, Dr. Jayati, for that really truly comprehensive elucidation of kidney involvement in infections. Actually, you have taken us all along a long journey through all the infections and envenomations and toxins that can have an impact on the kidneys and how the mechanism, as well as how we will be able to tackle these problems. And all the questions and doubts pertaining to this tropical infections and kidney can be left in the chat box, and we will move on to the next talk and we will discuss all the queries after the next talk. And next, we are moving on to a very hot topic, which is actually a real problem that we all face in the critically ill, sepsis, which is a major killer, a life-threatening organ dysfunction caused by dysregulated host response to infection, and early identification and appropriate management of this problem is going to improve the outcome, as we all know. But the pro-inflammatory and anti-inflammatory response that is there in the patient, which is actually responsible for, or which is actually fighting the bacteria or the virus or whatever infectious agent, but what is really causing the problem, and the homeostasis of the circulating mediators and the homeostasis that is important. We all know about the pathogen-associated molecular pattern, PAMs, and the damage-associated molecular patterns, DAMs, and the inflammatory cascade and cytokine storm, and the tissue and the organ damage. The house is on fire. That was what we were talking all these years, and how we are able to tackle the situation, whether the purification of the blood, the bacterial endotoxins which are there, or the inflammatory mediators which are produced by the body, which is going to be more harmful than good, whether removing this is going to improve the outcome. This is a new paradigm, that is blood purification in sepsis. What are the strategies for blood purification in patients who are with or without acute kidney injury? What is the mechanism by which these blood purification strategies are going to help? Do we have new devices specifically targeting the pathophysiology? Does it really help a septic child? And if it helps, what is the cost involved? Is it widely available? What is the outcome? What is the data available? So to discuss all this, we have got Dr. Sasidaran Kandasamy, who is a very young, enthusiastic intensivist, who is actually truly a 3-in-1 clinician, I will say. He has MD in pediatrics from PGI Chandigarh, followed by DM in pediatric critical care. He is one of the early clinicians to get that degree in India. And after that, he is also having he is also a pediatric nephrology trained, IPNA trained fellow. So he's truly a 3-in-1 person who is very much armed to treat a septic child in a critically ill critically ill child in a pediatric intensive care. And I am sure that Mehta's hospital is actually lucky to have a person like him in their team. And he is also having a DNB program. He's a program director for pediatric critical care DNB program at Mehta's Hospital. So we are all waiting to hear from you how this blood purification strategies are going to help a critically ill septic child. Over to Dr. Kandasamy for his talk.
Good evening, everyone. I hope I'm audible. Yeah. So next 30 to 40 minutes, what we are going to discuss about does the blood purification help a septic child? This is maybe I may consider that it is a very it's a very difficult question to answer. I'll try my level best to answer this question. Thank you, Susan, madam, for such a nice introduction and giving a complete preamble of what we are going to discuss about. With this, I'll go directly to the presentation. And the overview of the presentation, what we are going to discuss today is in the components of the following headings: management of sepsis, available treatment methods, and adjuvant therapy. So you have to quote the word adjuvant therapy. Blood purification is just one of the adjuvant therapies. It's not the primary or targeted therapeutic modality. Second, we will discuss about molecular basis of sepsis and targets of treatment. Then about blood purification methods in sepsis management. And then we will go to some case-based discussion to make everyone understand how we really do it pragmatically at the bedside. So these are all the treatment options available for anyone in sepsis. This is the figure taken from BMJ 2016 publication. If you see the list, there are a big number of interventions available. Antibiotics, vasopressors, fluids, in that colloids and crystalloids, and then enteral feeding, which has an important component in septic shock management, especially abdominal, insulin therapy plus minus, and lung protective ventilation, urine output measurement. All these are components of therapy. And there are some protocolized methodology of treating called goal-oriented therapy or yearly goal-directed therapy. And initially, people have been endorsing too much on deep sedation, and now it is a patient-controlled sedation. So that part is going out. So what is in gray zone has clearly mentioned here is molecular targeted therapies. Molecular targeted therapy, when we say molecular targeted therapy, it is still in the gray zone. You can't put it as a targeted therapy in kind of like a targeted treatment in sepsis, but this is a adjuvant therapy. So what are all the things classified as molecular targeted therapy? Extracorporeal blood purification, immunotherapy, and cellular therapy. Immunotherapy and cellular therapy are more advanced and really not a bedside methodology as of now in a whole world. So our concentration of discussion is going to be on extracorporeal blood purification therapy. So first we need to know about sepsis pathobiology and what we target in blood purification therapy. This has been already given in nutshell by Susan madam in one of her slides. So whenever there is an infection, there is a pathogen associated molecular proteins and damage associated molecular proteins from molecular patterns. These are all proteins from a host which react and stimulate endogenous activation of multiple cytokines. So what happens in eventuality is there is an excess of inflammatory cytokine resulting in hypercytokinemia. So along with this hypercytokinemia, more easily understandable and familiar terminology after COVID is cytokine storm. So after the cytokine storm, there is cascade of reactions in host immune mechanism and inflammatory mechanism of the host as well in the coagulation mechanism. Just to understand it clearly, we will put it under two baskets. One basket contains coagulation mechanism, abnormality. Another basket contains immune dysregulation. Okay, so with this, when we go to the next understanding a little bit more about these two aberrations, first we will go into the coagulation aberration. So this is a very complex photograph, which you need not go through every step. What you need to understand is given here in nutshell. Dysregulation of coagulation cascade, that is through contact activation process, results in immunothrombosis, disseminated intravascular coagulation, multi-system organ failure, and eventuality is mortality. So this is what happens when the disruption in the coagulation cascade happens due to hypercytokinemia or cytokine storm. Now we go to the next basket, which is a immune dysregulation or immune aberration. So immune aberration, there are multiple theories. You may be knowing the cytokine peaking theory by Dr. Ronco, and there is a immune imbalance theory, and there is a cellular theory. So what we need to understand is there is always a balance to be maintained between pro-inflammatory cytokines and anti-inflammatory cytokines. So when we are able to maintain the balance between pro-inflammatory and anti-inflammatory cytokines, things are going well. When it is below the toxic threshold, things are going well. When it goes up and above the toxic threshold, when there is an overlap and peaking of pro-inflammatory cytokine happens, there is a background injury initiation. Over the time, it will evolve into organ dysfunction. So if this immune aberration getting controlled on its own, or through immunomodulatory medications, or through blood purification therapy, then the recovery is possible. It is not that we have to always institute blood purification therapy to go to recovery. It can happen on its own, or through immunomodulatory medications, or through blood purification process. So this is about immune dysregulation. So first thing is we need to understand the coagulation cascade, what is the disruption is going to happen. Second important component is what is going to happen in immune dysregulation. So now on this context, we will go to our topic of interest today, that is blood purification, how this blood purification is supposed to work. All these are not very strong evidence-based evolution of ideas. Maybe these are all currently only hypothesis. So the removal of pathogens. So here, this is a pathogen cell, and this is a host damaged cell, and this is a host immune cell. So there is an interaction between pathogen, host damaged cell, and host immune cell. So this is what is creating all the cytokine storm. So removing pathogens from the blood, removing the endotoxins or pathogen-associated molecular patterns, or removing the activated leukocytes and reprogramming the circulating leukocytes, or reducing the cytokines in the blood level. Either of four can be the mechanism in blood purification therapy. And I want to reiterate that this is not evidence-based evolution. This is just a hypothesis and concept. So this is again a pictorial depiction of what we have already told. Either the cytokine removal through the cytokine gradient, or leukocyte removal. This is just for reprogramming of the cellular mechanism to attain immune homeostasis, or bacteria or endotoxin removal. These are all could be the mechanisms. So on this background, we need to understand what are all the things available in the menu card, what is available in your armamentarium. So you may not be having everything in your unit. Something would have been there in your unit. Just to understand it better, we go through the evolution of technology. So 1980s, you would have seen in every CRRT book, or the Claudio Ronco's the first newborn who's undergoing a CRRT session. So that's in the year 1981. So from then onwards, there was a huge development in cartridge, machinery, membranes, all these three. Cartridge, machinery, and membranes. So all these three. So all these three has evolved over time to provide you the so-called fourth generation CRRT machine and the extracorporeal multi-organ support system as a single unit. This is what we have reached in 2020. But you need to know that this is not that we have to do everything with this state-of-the-art 2020 machines. Most of the time, we may be having one among this evolution order. So we may be having a third generation CRRT machine, or we may be having a third generation CRRT machine with a hemodialysis machine, which can do a kind of total plasma exchange. And you may be having cytosorbs and other filters, and you may be having a liver support system that is called MAS if you are having a liver transplant unit. Based on the available thing, you may need to choose your modality. So in 2020, where we are, this is a simple depiction given as a diagrammatic depiction given by Dr. Claudio Ronco and group in one of their review on CRRT or blood purification methods in COVID. So there are many supportive methods. As an intensivist, you may be familiar with most of these terminologies. So just for better understanding, I'll go through one by one. This is called ECHO2R. ECHO2R is extracorporeal CO2 removal system. This is a very important system currently used as an adjuvant to ventilation to avoid full-blown ECMO or extracorporeal membrane oxygenation. And there is a big list of CRRT, that is CVBH, CVBHD, CVBHDF, done by the classic CRRT mission. And there are hybrid missions which are helping you to do SLED, SLEDF, and SCUF. SCUF, most commonly, we may not see that as a RRT modality. This is only an ultrafiltration modality which may be useful to remove fluid in kind of a congestive heart failure management or extreme fluid overload, otherwise absolutely normal patient in pediatrics, which is quite uncommon. So SCUF is not a commonly used modality. The another one is plasma exchange or total plasma exchange based on the calculated volume of exchange. Then hemoperfusion filters. This is adsorption hemodialysis. This is a kind of an hybrid therapy. And then MARS, which is for liver support. And then here is VV ECMO. So for a simple understanding, you can make it like what is a renal support and related methods, which you may be very familiar, like CVBH, CVBHD, CVBHDF, SLED, SLEDF, and all those. What is oxygenation and ventilation support with the cardiac support, that is VV ECMO, VA ECMO, ECHO2R. And then other organ support system like MARS for liver support, and completely another subset which we may have a relatively recent interest, that is about adsorptive methods in sepsis or cytokine removal or endotoxin removal. So this is almost a kind of repetition. So in sepsis, what are all the modalities you can use? You can either use convective therapies, conventional CRRT, or high volume chemofiltration or very high volume chemofiltration, high cutoff chemofiltration. So when you say about the evidence, conventional CRRT is as good as very high volume or high volume chemofiltration. What have been told by many studies is that by increasing the effluent rate up and about 25 or 30 ml per kg per hour, you are not going to achieve anything great or a great cytokine removal or something different in the mortality or other surrogate outcomes. When you go to other therapies, these are all predominantly adsorptive or mixed therapy. Oxidase is a mixed therapy model. Cytosorb is a adsorptive therapy model of cytokine adsorption. Then perfusion adsorptive therapy, which is a polymyxin column, which is commonly called as toremyxin, based on this company Torre. This is toremyxin. That is the filter name. Hybrid therapies like CPFA, this is a coupled plasma filtration adsorption. Here I need to say that the Compact 1 study and Compact 2 study, which have studied on coupled plasma filtration adsorption, the Compact 2 study has been stopped because of more amount of adverse events in a therapeutic arm. So CPFA is losing its charm. So we may concentrate too much on CRRT or adsorptive technique. That's the current status. So now we go to the next session of this discussion. That is, like, I have given you an overview about what are all the things available and how it has evolved over time, what is the basics, and what are the hypothetical model of working in all this septic shock patients when you use a blood purification. And simultaneously, I have given you an intro to say that convective therapeutic modalities of CRRT is also considered and also called as blood purification technique. So now the first and most important question to answer is when to start blood purification in sepsis. When we know about the menu card, so what to choose and when to choose, whether it's breakfast or lunch or dinner, accordingly we have to choose. So when we want to ask this question, there are two methods of answering this question. So you can go through the evidence review, and I can put a table and say that this is what the evidence says. Obviously, I didn't choose that modality because you all know that the evidence is going to say that simple one word answer, the evidence is not adequate to suggest blood purification in all septic shock patients. So that's why I am going through another modality, which is a kind of an analytical method to explain what is the role or what could be the role of blood purification therapy. So here, always the principle is we always learn from failure. So I am going to discuss 3 failure scenarios. So case A, where the outcome is death, case B, where the outcome is death, case C, the outcome is nothing other than death. So the 3 failure scenarios to understand about this question and answering this question. A is a 4-year-old male child, fever of 48 hours, blackish skin lesions for 12 hours duration. Child had lethargy, depressed sensorium. This child has been brought to ER in refractory shock. Child has been given fluid bolus and steroids. Adrenaline, norepinephrine, vasopressin has been started and progressively increasing. Respiratory distress is also worsening. Child had seizures, aborted with anti-epileptic medications. Child had anuria at the time of admission itself. The first dose antibiotic supposed to be the second line cover have been given because of the sickness of the child. Albumin resuscitation, failed PRBC transfusion, FFP transfusion, everything given back to back. But at the end of 58 hours of hospital stay, the child, at the end of 8 hours of hospital stay, the child dies. So this is the outcome. And here, the child is having sepsis, multi-organ dysfunction. Refractory septic shock, blood culture post-demise collected is showing Pseudomonas growth. So now we go to the case B. This is a similar 2-year 9-month-old male child, fever of 9 days, cough and cold for 7 days, breathing difficulty for 3 days, lethargy, depressed sensorium. Child is in refractory shock, Similar way, fluid bolus, steroids as an adjuvant, maximum inotropic agents, liver synthetic dysfunction, ET bleed, antibiotics. This child, 4 hours of hospital stay, the child dies. Okay, so here, sepsis, multi-organ dysfunction, refractory septic shock. Obviously, we didn't know anything at the end of 4 hours. So this is post-demise sample collection. This is a H1N1 positive child. Blood culture was showing Streptococcus pneumoniae. Okay, so now we go to the diagnostic workup in these 2 patients. This is a very important slide. The hemoglobin was low. TLC is 34,500, which is leukocytosis in case A. Case B is showing only 800. That is a highly neutropenic leukopenic count. Platelet count is low in both. INR was high. Ferritin is high. LDH is high, and OTPT in thousands. So case A is Pseudomonas aeruginosa positive at 48 hours of culture. Case B is H1N1 positive with a secondary complication due to Streptococcus pneumoniae. This child came after 8 days of illness, so it is a kind of a late presentation. So now we go to case C because it's a tropical country. When we discuss about sepsis, we have to discuss about sepsis, tropical infection, that is undifferentiated tropical fever associated shock, and currently we have to discuss about COVID also. So this is a case C, which is an 8-year-old male child, fever of 4 days duration, irritability, altered sensorium, breathing difficulty for 1 day, fever was continuous more than 101 degree Fahrenheit. The child has encephalopathy, dengue IgM positive, child had shock, thrombocytopenia, minimal GI bleed to begin with at the time of admission. Child had seizures, respiratory distress, anuric. The child on day 7 has been started on CRRT and albumin resuscitation, PRBC transfusion, MPS, methylprednisolone pulse therapy. The child progressed to acute liver failure, coagulopathy, and bleed. The child has stayed in hospital for quite a long duration, maybe 6 days. And the child has a very resistant fulminant hepatic failure due to dengue and shifted elsewhere for liver transplantation. But before getting the liver transplant, the child dies due to the primary disease. So severe dengue, hyperferritinemic multi-organ dysfunction syndrome, fulminant hepatic failure, AKI, KDIGO 3. So now there is a very important question, why there is an incomplete response to anti-infective therapy. All these are infections. So, okay, dengue, we don't have a particular drug, but all other places we have started a medication, which is quite effective, supposed to be antibiotic, which covers the post-demise culture, showing the whatever the organism, but still our outcome was failure. So this is a late initiation of anti-infective medication. Usually we encounter this as a cause. This could be inadequate anti-infective cover. This is not likely in first 2 cases, but it can be in a case where the child dies due to septic shock. Secondary infection or concomitant infection. This is a case in case B, what we have discussed, that secondary infection associated with H1N1, Streptococcus pneumonia, that could be the cause. So what is the difference in these cases from the garden variety case which comes to PICU and the outcome is rosy, the child recovers and goes home? Risk of mortality. Risk of mortality in any child admitted to ICU can be high, moderate, or low. So we will discuss what is high, moderate, low. So it means that there is a heterogeneity in phenotype of each individual patient. And immune dysregulation complicating the disease pathway is highly likely and notorious to pull a patient towards a negative outcome pathway. So here we need to understand a concept called extreme immune phenotypes in sepsis. So the incomplete response to anti-infective therapy need not always be because your delay in anti-infective therapy or because of incomplete coverage or because of the secondary infection which you never thought of. It can be because of extreme immune phenotype, which is a crux in the mechanism of injury. So to understand this, we go through this diagram. This is called immune homeostasis. This straight line is immune homeostasis. This is the timeline, day 2, 4, 6, 8, 10, 12. So what happens when there is a hyperinflammatory response unchecked, unverified? There can be early deaths due to overwhelming inflammation. So can you put our patients into this paradigm? Yes, the early death due to overwhelming inflammation, which is that happened in a Pseudomonas sepsis child. Okay, so next thing is late deaths due to persistent immunosuppression and recurrent infection. What happened? The primary disease is H1N1 pneumonia. Child stays with fever at home for 6-7 days, comes very late. At that time, the child is having count of 800. It is in the immunoparalytic stage where whatever drugs you are thinking and giving us in anti-infective therapy is not great enough to counter the effect. So this is a classic example of late deaths due to persistent immunosuppression and recurrent infection. So now there is a theory 2. I am not going into theories, just to give you a conceptual understanding. So now there is another case scenario which we have discussed, case C. That is late death due to intractable inflammation induced organ injury. So all these 3 immune paradigms can happen and cause demise in critically ill patients, especially who are having sepsis and septic shock. This is the very, very important component to understand. So from failure, we understood that there is something called extreme immune phenotype exists. And these immune phenotypes we can fit into our index patients. So in such circumstance, now we ask the same question again. When to start blood purification in sepsis? How to decide the need for blood purification in an index case? I have already discussed 3 cases. So we have put another question, how to decide need for blood purification in an index case. I am not trying to say that all these children would have survived if we would have put on CVVHDF or some kind of blood purification therapy. To understand that, we have to go through this conceptual framework. This is a very, very simple diagram. So why it is very simple? This diagram, if you understand, most of the difficult decisions in critical care or any hospital medicine, you would be able to take a decision. So with this, we have to go through this. So this is a x-axis which says the mortality in study population. So sepsis, severe sepsis is our study population. The mortality is 10%, 20%, 30%, 40%, 50, 60, 70, 80, 90%. So here there is risk reduction. This is what we are aiming by any kind of intervention. There is something called threshold here. The threshold is an intercept between your benefit, which is a diagonal line here, the yellow line, and the harm line, which is a horizontal green line. So the intercept is your threshold. The threshold is to differentiate low-risk patients from moderate to high-risk patients. Why I say moderate to high-risk? More than 30% mortality is considered as moderate to high-risk patient. If your index case has more than 30% risk of mortality, I would classify them in this zone. If they have less than 30% mortality risk, I will classify them in the lower zone. So when we say about risk reduction, you see this low risk area when you do an intervention, which is an invasive intervention, which has a potential adverse event, like a blood purification therapy. What happens? The net harm is high. You may not be able to justify that intervention at all. So when you go to the up and above this green line, yellow line intercept, where the mortality risk is more than 30%, up and above 30, up to 90%, here the net benefit, the magnitude of risk reduction is quite high. So when we put this into our concept, every invasive intervention carries a risk of adverse effect. This everyone will understand and accept. When an index case is at high risk, benefit would outweigh the risk. This is not clear if the index case is at the low risk. So this is a very, very important component to understand when we intervene a patient with a highly invasive intervention, which has a potential to cause an adverse effect always. So we put our available data into this segments. So what is happening? This is a 2017, not very old, meta-analysis of effects of polymyxin B hemoperfusion on mortality in patients with severe sepsis. The idea here is disease severity subgroup meta-analysis. This is what is very important. So they have defined low disease severity when the risk of mortality is less than 30%. When the risk of mortality is more than 30%, they consider that as high risk or intermediate risk. So you plot your forest plots, which is available in this meta-analysis. You see here, intermediate and high risk, it's towards, that is favoring the polymyxin hemoperfusion. When you go to low risk patients, obviously it is not favoring. It is favoring the conventional methodology of treatment. This is very, very important to understand when we are treating a very sick patient. So based on the control group mortality, you have to take a decision. So now all these are adult data. So that meta-analysis, anybody can say that it's an adult data. So how to decide in children? Concepts are same, but we have to consider one other important thing. What is the post-discharge organ outcome? So you know that I have just given a kidney as a reference here. So this is the AKA trajectories from ATKI 2017. So it can be up and down. So you may evolve into acute kidney disease, chronic kidney disease, and all these are possible. At the time of discharge, if the patient is not on dialysis, doesn't mean that the patient's organ, kidney as an organ, recovered completely. So this we have to keep along with the net benefit factor to decide about blood purification therapy. And another important thing is, in pediatric ICU population, the baseline study population mortality is not 30%, 40%, 60% like in elderly adults. So we have to have surrogate markers, duration of PICU stay, ventilation-free days, vasoactive-free days, organ function status at discharge as our outcome metric in most of our studies. Whether such a study exists, till now there is no such study. So it is very difficult to say based on evidence whether we recommend blood purification therapy or not. So can we conclude here saying that we cannot? No. At bedside, we do blood purification therapy. So here we go to case-based individualized approach. This is the another case where it's a 5-year-old male child, fever of 4 days, cough and cold for 4 days, lethargy and depression, sensorium for 24 hours, reduced urine output for 24 hours. The child is having a septic shock, fluid bolus, and epinephrine. Antibiotics have been started. Child is admitted in our ICU. It has been found to be a catecholamine resistant shock after reaching epi of 0.3 and nor-epi of 0.2. Hydrocortisone, shock dose, and other adjunctive medications which are used in our unit have been given. A child has been intubated, mechanically ventilated, CV line, ART line, everything in place. Lactate is unfavorable, that is number 6, and the ejection fraction is 45%. So what happens here? This child requires a filtration technique because this is a kind of a very high mortality probability child. So that is, I can't say that objectively, because objectively you can say lactate, you can say procal, you can say more than one organ involvement, you can say ejection fraction is only 45%, but you have to make a contextual understanding this child requires a blood purification therapy. So what are all the options available to us? So you can use CVVHDF or CVVH. As I already told, the effluent dose increase doesn't make sense. So effluent dose standard is 25 ml per kg per hour. There are studies using high volume as well, very high volume, like IVOID trial, where they used 75 ml per kg per hour as a effluent dose, but all these didn't favor the outcome. So the standard dose therapy is quite okay based on the current evidence. Adsorption methods are available. Cytosorb, toromyxin, and oxyrus filters are available. CRRT method plus total plasma exchange you can try. And advanced combination therapy methods are available in some units, may not be always possible in our unit. So what are all the available methods? This is the CVVH or CVVHDF. If you use replacement fluid, you call it a CVVH. You use replacement as well dialysate fluid, then it is CVVHDF. Only dialysis, then it is CVVHD. When you say about blood purification method, we consider CVVHDF and CVVH as blood purification method, unlikely to consider CVBHD as a blood purification method. So here there is a Torre mix-in filter. So there are 3 sizes of filters available in world market, but unfortunately only this 3R filter is available, which can be used more than 35 kg body weight in India. So there are units which use this filter in pediatric patients up and above 20 kgs, but ideally it can be used only above 35 kg, what is available in India. And there is an Oxyris filter. This is a very a nice and easy working filter, which can be a continuous renal replacement therapy filter along with adsorptive clearance. So this we use in our unit very rarely, but not very commonly used, but this is a quite user-friendly methodology. Then there is an cytosorb, which is commonly used in adult units. Adult units in COVID, they right and left use cytosorb filters, but our experience with cytosorb filter is very less. And another thing to quote here is, again, there is a weight limitation in cytosorb filter. More than 35 kg only you can use the available filter as per recommendation. So comparing the available blood purification membranes and cartridges, there are many things. One is, what is the filtration capacity? So you can say is a cutoff based, what is the filtration capacity? So Oxyris filters up to 35 kilodalton, Torre mix-in filters up to 65 kilodalton. So obviously 66 kilodalton is the molecular weight of albumin. When Torre is used, the time should be not more than 6 hours. Otherwise, you end up in huge protein loss. It can go up to 8 to 28 grams per day of albumin loss as per the adult studies. So it's quite dangerous. We have to be using only for 6 hours per session, maximum 7 consecutive days. That's what has been used in studies. A cytosorb can absorb up to 60 kilodalton molecules. Because it is an adsorption technique, usually albumin loss is less, but still it happens. AN69 Oxyris filter, it is a very reasonably okay filter, which doesn't cause too much amount of protein loss, and it can be continuously used. It is a dual purpose filter. It is a CRRT filter as well, adsorptive capacity filter. But you have to note that here, hydrophilic antibiotics can be removed. All other adsorptive methods, lipophilic antibiotics can be removed. The antibiotic dosing have to be extremely careful. You should be knowing there is something called augmented renal clearance in septic shock hyperdynamic patients. So the routine way of reducing the dose of antibiotic should never be done when a patient is on CRRT. Maybe additional dose may be required based on the lipophilic character of the drug. So how to select a treatment method? The simple way to select is protocol-based approach. It has to be a unit-specific protocol, and one-line answer is select a method more familiar to your unit. For intensivist, I can say that it is just like your ventilation selection. When volume control mode or pressure control mode, the final answer will be what mode your unit is familiar with. The same way, select a mode which is more familiar to your unit. What happened in the index child? This is diagnosed to be a MRSA sepsis, CVBHDF. This is the prescription we used, M60 cassette with the dialysate flow starting at blood flow starting at 50 ml per minute, increasing to 90. This is just to reduce the probability of crash. And this is the total amount of effluent calculated is 37.5 ml. And we have divided 1:5 replacement and dialysis. Dialysate flow, because we wanted predominantly convective clearance in this index child. So what happened subsequently, this child had a very bad hemoglobinuria, so mandated 2 sessions of Plex as well. This is the clinical photograph, the peripheral gangrene which is evolving over time, and this is the urea creatinine trend, and this is just to show that multi-organ involvement. INR is high, platelets low, extremely high CPK value with hemoglobinuria, which mandated a Plex. CRRT was stopped on a 5th day. No further Plex was required. Minimal ventilation support, no bleeds, peripheral gangrene is still present. So many times what we think is, when we do an adventurous procedure like this in a very sick child, the child has to recover immediately. That doesn't happen so. Because the contribution to outcome by this methodology is somewhat there, but it is not that it is a magic. So it is not a magic that it will just make the child sit the next day and third day the child can be discharged. This cannot happen. We have completed the blood purification therapy in this child, but does it solve the puzzle? No, you have a long way to go. What happened on day 5? CRRT stopped, hemodynamic stable, off vasoactive. Day 6, the child has been extubated. We are all very happy. But subsequently, there is a failed extubation because of pulmonary edema. Pulmonary edema, you can clearly denote in this X-ray picture. And day 6 itself, within the same day, the child has got re-intubated. And later required 3 sessions of IHD as well. Chest X-ray was improving. The CV line has been removed. And day 10, the child has been extubated to HFNC. Whether the story ends there? No. There are many more things are there. So the gangrene worsens, and the child is again started to have fever. Fever workup was negative. Day 21, there is post-discharge from the skin over the left lateral malleolus. If you would have seen the clinical photograph, this is one of the sites of the gangrenous development. Culture grows MRSA after 20 days of Vanco. So we have to escalate the antibiotics and every other thing. And fever is passive by day 35. The child discharged on day 40. But only great thing is the child is completely neurologically intact. And this is a follow-up figure, which is showing the child is having some amount of loss of finger, but the functionality is completely resumed. And the upper limb and lower limb, there is no functional limitations. So what we can say is, to achieve this much amount of intact outcome, blood purification has a role. But it is not that blood purification is a magic to cause every patient ready for discharge within 3 days. So this is another case. I'll finish a discussion with this case in next 5 minutes. This is a 7-year-old male child, fever of 8 days, conjunctival congestion for 2 days, reduced urine output for 24 hours. The child had fever of more than 1 or 2 degrees Fahrenheit. Outside, the child has been treated with paracetamol and mefenamic acid. Presents to us on day 8 of illness in hypotensive shock, requiring fluid bolus, epinephrine, antibiotics, ceftriaxone, and doxycycline added. Admitted in PICU, the child develops into catecholamine resistant shock, epinephrine 0.2, norepi 0.1. History of contact with COVID positive adult 6 weeks back, hence kept the possibility of MISC. Child has been intubated, mechanically ventilated. CV and outline have been secured. Ejection fraction to begin with 45%. But there is no bad coronary dilatation. Lactate was 4.2. So at this juncture, so we have to see the creatinine trends, which was unusual. We have seen many MISC patients. At least 5 patients till now have underwent a CRRT support. Other patients didn't require CRRT. That is a very good chunk. More than around 18 to 20 patients in 3 places where I see critically sick patients. We have seen MISC, but only 5 patients required a CRRT support. That too, especially because of relatively late presentation. But this is a different child. Creatinine to begin with was 2.8. So here we have given IVIG and MPS. COVID antibody titer was 144.5. In this child, there is another contributory cause. It could be mefenamic acid as well, could be a contributory cause in this child. This child has been put on CVVHDF. The creatinine has started showing a reducing trend. CRRT stopped on day 4, extubated on day 5, discharged on day 7 on oral steroids. These kind of children, like COVID children, presenting with AKI or presenting with a very refractory shock, they respond reasonably well and reasonably very fast to CVVHDF. Usually, patients will get discharged on 6th or 7th day, even though they present with a refractory shock and ejection fraction, which is reasonably low. And another thing is, even though ejection fraction is 40, 45, or 35%, even in our last child, it was 38% documented EF, we can comfortably do CVVHDF. So blood purification has a big role in COVID, as you all know. I'm not going into this diagram. So there is a paper, multiple papers saying the role. Here we conclude, sepsis management, chemofiltration has a role. identification of extreme phenotypes and time the BPT, that is blood purification therapy, accordingly, and time-sensitive immune modulation, part of multi-organ dysfunction syndrome management. Immune constitution of the sick child is constantly changing, hence continuous monitoring is more important beyond the right timing of blood purification therapy. This is more important. You have timed the blood purification therapy rightly, maybe yearly. That doesn't mean that everything can be cut short and the patient can be discharged within few days. Here, the other supportive measures are very important. Hemofiltration has a role as adjuvant therapy in sepsis with extreme phenotypes where the risk of mortality is quite high. So this is a kind of a summary slide. If you want to understand when to start blood purification, so this is a kind of anti-inflammatory and pro-inflammatory paradigm. The phase A here is adaptive immune response, extracorporeal therapy likely to be harmful. This may be the low risk zone where the patient, they themselves may recover. Phase B is cytokine storm, likely maximal benefit from extracorporeal therapy. This is the phase B. Phase C is counteractive anti-inflammatory arm, restoring immune behavior. And this is can be restoring, or sometime it may be progressing to immune paralysis with very low counts, which we have seen in the initial case of Pseudomonas sepsis. These kind of patients, many times, the extracorporeal therapy may not work. So we have to identify this B phase and institute blood purification. Unfortunately, though we say that procalcitonin and endotoxin activity assay and to an extent IL-6 levels may indicate you when to start blood purification therapy, there are no great objective guidelines available even in adults. Thank you.
Thank you, Dr. Sasidhar, for that wonderful talk and taking us along a new new armamentarium that is available, which can actually save many kids. And I was projecting in my initial slides, what is the cost of therapy that you had actually come across in these kids who have actually survived, and specifically for this blood purification strategies.
Yeah,
that is one question. Second question is, a child with shock and the scatecholamine refractory shock, when you are taking the blood out with an ejection fraction which is very low, do you refill the circuit before you start the procedure?
Can I take up the questions, ma'am? Yeah. So the first question is cost of the therapy. So that's a very interesting part to the therapeutic model which has been projected. Purposefully, I have avoided putting the cost analysis because it's not very attractive. I have to be very truthful. It is not very attractive number we will get. So, for example, if you are doing a CVVHDF, maybe in a very sick child who has already been on invasive ventilation, in any multi-speciality PICU, per day, the cost for the therapies, these therapies alone, for example, CVVHDF alone, may be adding to 30 to 35,000 of your base cost. Adding to 30 to 35,000 of the base cost. So what are all the things can modify this is by improving the unit structure and a dedicated person, like for example, for us, Dr. Kalaivani is involved in most of our, almost all of our critical care extracorporeal procedures. So what happens is over the time, our longevity of filters will improve. And our coagulation, anticoagulation methodology would improve. Our monitoring techniques would improve. And our, for example, we may not monitor calcium every 4 hourly. We know that this much calcium have to be replaced if we are doing once in 12 hourly calcium monitoring. And the blood component therapy requirement may not be very much when the unit's experience increases. So in this way, we can reduce the cost, but we cannot cut the cost completely. So the cost will be a factor. And here, another thing is, for example, in JIPMER, this CRRT filters are very easily available. So some places, for example, very, very specific places where the filters are sponsored by the government hospital, I think that is the best place to develop a state-of-art extracorporeal therapy center. So in that way, it may be quite feasible. Otherwise, access for everyone for blood purification therapy is really limited because of the cost. That is one. Second is about blood priming. There are 2-3 ways in which we can avoid the hemodynamic instability. One is like Kalaivani will agree. So most of the AN69 filters, we will start with bicarb priming, and then pre-initiation itself, we will decide what is your threshold hemoglobin in our index case. Usually, we will try to keep something close to 10 or close to 9 before initiation of CVVHDF. And if it is a very small child, like a less than 15 kg child, or EF is something close to 30%, 25%, maybe blood priming is a mandate. Otherwise, blood priming is not always a mandate. Third component is you can start with a very low blood flow rate in a proper CRRT machine. If you are using hybrid machine, the lowest blood flow rate may be an issue. In SLED machines, the lowest blood flow rate may be an issue, but it's not the case in CRRT machine. You can start with a very low blood flow rate, and you can progressively increase the blood flow rate. That is another method. And fourth thing is we can anticipatedly increase the pressure agents in our armamentarium. So already the patient is on epinephrine and norepinephrine. BPs are not very great. The BP is MAP is not at 50th percentile. So I would try to put a low dose vasopress infusion just for the initiation purpose. Maybe after 6 hours I can taper and stop it. So many of these things can be helpful, not only blood prime. Thank you, ma'am.
One more question is, are you more comfortable with citrate anticoagulation or heparin in your unit?
So, I am completely uncomfortable with citrate anticoagulation because I am not, because I am a very conventional person, ma'am. Because I don't experiment new things. I have a very very high threshold to experiment new things. When
you were talking about you were talking about calcium monitoring. That is why the question came.
Yes, ma'am. So the thing is, the citrate. When I'm saying about calcium monitoring, I don't have much experience about citrate regional anticoagulation. In citrate regional anticoagulation, we cannot limit the calcium testing. So even any kind of ABBHDF, we use a high effluent rate around 35, 40. Most of the time, we have to frequently monitor calcium, phosphate, and potassium. So that is the monitoring parameter I was speaking about. Citrate anticoagulation, I am little hesitant. So that is why I don't do that. I don't even allow people to do that. So I can't comment much about it, ma'am.
Yeah, inviting more questions from the delegates. Dr. Jayati, any question you are having for Dr. Sasidar?
Yeah, that was a wonderful presentation. I mean, totally opened up this thing very well. Just a small question, because about this MISC, you said that they are using cytosol very rampantly in adults. So how does the cytosol, how will the cytosol be so difficult or not the right choice for children? I mean, why?
Okay, ma'am. So basically, in MISC, the mechanism is a little different, ma'am. So though it is a cytokine-mediated mechanism, the cytokine removal per se may not endorse the good clinical outcome. So that is why the primary therapy remains to be intravenous immunoglobulin, like Kawasaki disease protocol. So 2 gram per kg of immunoglobulin, followed by another silencing drug, which is the intravenous dose of methylprednisolone, not mega dose or the 30 milligram per kg dose of methylprednisolone, not as the pulse dose. Usually it is between 1 to 2 milligram per kg and slow tapering. This is the protocol for MISC. And CRRT has always been used as a organ-specific modality. In children with EKI, they have used, or in children with refractory shock, they have used. But in case of adult, it is a concurrent infection. The PCR positive adult who is presenting with a very bad pneumonia and progressing to multi-organ system failure, IL-6 is coming in 150,000, 2,000, something like that. That is a concurrent inflammatory paradigm. Along with the PCR positivity, there is an inflammatory excess state which is happening, where people use cytosorb because they believe that cytosorb may remove pro-inflammatory cytokines like IL-6. So cytosorb is not used in MISC. This is only organ-specific or refractory shock-specific therapy. In adult, the context is completely different.
Yes, I'm sure that is it. Because when the patient who presented with MIS to us, I mean, it was just IVIG and methylprednisolone. Has been more or less okay, except in one patient we needed remdesivir. Though it was more of a.
Ma'am, can you come closer to the system and speak, ma'am? Your voice is breaking.
Oh.
Sengupta, can you please come closer to the system? Your voice is little breaking.
Okay. No, it's okay. Thank you. I mean, I completely agree with your point. Yes.
Okay, thank you.
Dr. Kalaivani,
I think we have one more question for Dr. Sasidaran in the question box. Would you like to take up, sir?
Yeah, you can say that. You can ask that because.
Any role in sickle cell with dengue shock with multi-organ failure? What is the role of blood purification therapy?
Sickle cell disease with dengue shock.
Dengue shock with multi-organ failure. Is there any role for blood purification therapy?
Okay. There are two components to the question. It is highly complicated. So, sickle cell disease, developing a tropical infection. We know very well that sickle cell presenting in disseminate like Salmonella sepsis, they can go into a very sick state. In that cases, because of gram-negative septicemia, people have used adsorptive methods and CVVHDF. So that is a completely different connotation. So a gram-negative sepsis, like a Salmonella sepsis, where they are very prone for Salmonella, and the basic disease is sickle cell, and CVVHDF have been tried. So this is a very complex scenario. Dengue shock per se, when it is going for a multi-organ system failure, there are two parts to that. One is a very bad fulminant hepatic failure. Another is progressive acute renal injury. So that progressive acute renal injury, most of the time, is not very, very difficult to manage. With any kind of CRRT, with a reasonable amount of effluent dose, with a convective clearance, you can control the creatinine. But the major problem will be the progressive hepatic failure. That fulminant hepatic failure, though we say we can try flex with CVVHDF, whatever limited number of cases we have have tried Plex with CVVHDF in a dengue shock. We didn't have an excellent outcome. At least I can say that we were not able to avoid a liver transplant situation. So it is a very difficult scenario. So now putting these two pieces together, it is much more complex. A sickle cell disease child having a dengue shock, having a multi-organ dysfunction syndrome. If your hemodynamics first allow you, you can try a methodology which is accessible to you. But I can't say that evidence-based, and I can't vouch you that how the outcome will be.
Okay, there is one more question from Dr. Swati Bharadwaj. Does CRRT carry risk of worsening of ICP in patients with pre-existing raised ICP? Question to Dr. Sasidaran.
I think she herself has given an answer. So in a raised ICP situation, if you end up in choosing a dialytic methodology, you are very much worried about ICP. So ICP fluctuations will be very bad following any kind of dialysis methodology. In that, the safest is CRRT. So among the hemodialytic methods, including SLED, SCUF, IHD, whatever method you have, peritoneal dialysis and CRRT would be the smooth methods which is happening over 24 hours time period. So peritoneal dialysis and CRRT are better methods compared to other dialytic methods in a child with raised ICP.
Dr. Jayati, do you find any difference in the evolution of infection-related glomerulonephritis these days?
One thing is that the nephritic syndromes, which used to be, much mainly, in PSGN would improve very fast. Have recently we find that many of them are going into RPGN or any other complicated course. So that is one thing we have found. But the total incidence of probably post-streptococcal nephritis has reduced to some extent, except for sudden clustering of cases. But the complications of the disease seem to be on the rise. The progress being more and more worse progress. The progression is more towards renal failure.
Yeah, there is one more question which has come, that is, any precaution to be taken while starting CRRT in patients with raised ICP? What all precautions need to be taken?
Okay,
Dr. Sasidaran.
So basically, raised ICP is a kind of scenario which may be coupled with many other basic diseases. For example, acute encephalitis child may be having a raised ICP. A traumatic brain injury child can be having a raised ICP. A fulminant hepatic failure child may be having a raised ICP. Septic encephalopathy child may be having a raised ICP. So primary disease management and primary disease control is of paramount importance. If I say traumatic brain injury, you know that the 72 hours, the traumatic brain injury related ICP is going to be worse. So your osmolar therapy and setting the targets of right BP, that is 50th percentile of BP, and head in neutral position, and proper sedoanalgesic medications, and proper bladder catheterization to avoid bladder distension and raised ICP spike, and proper NG tube and drainage. All these supportive measures are very, very important. And these are all primary disease specific. So these are all very important to be set right before even securing a hemodialysis catheter. So once you secure the hemodialysis catheter, you make sure that what is your hemoglobin threshold in your unit for a traumatic brain injury child. Make sure that is there. And whether the calcium is okay, the pre-dialysis calcium is okay. So the child has already having a high tendency to seize. The seizure tendency is quite high. So you can't create a precipitant hypocalcemia to seize. So all these things also need to get corrected. If the child is acidotic, you have to consider that as well in your constitution of fluids, if you are especially using a peritoneal dialysis, not in CRRT, but in peritoneal dialysis at least. So all these, and what is your sodium level? That is another very important. Your sodium target in raised ICP is around 150 to 155. Your diluted sodium in CRRT is 140. The standard Prismasol solution contains 140. Maybe it's 130 in PDE fluid. So you have to be very cautious about the sodium gradient. So you should not cause a bad drop of sodium. There is an excellent paper by SIN et al. Which says how to correct the sodium gradient in targeted hypernatremia in raised ICP patients. So all these things we have to take into consideration when we treat a raised ICP patient with the CVVHDF modality.
Yeah, thank you, Dr. Sasidar. And actually, in the first 3 cases that you had presented, all the 3 kids died within 24 hours. And one thing that was noticed was all 3 of them were anuric. So do you actually give a lot of importance to fluid overload, calculate that and make your decisions based on that?
Yes, ma'am. So we give huge importance to fluid overload. The whole world, the trend of intensive care has changed from one direction to another direction. People used to say that whenever we see ICU ventilated patient, they will be puffed up. That was maybe 10 to 12 years ago. Now there is a paradigm shift. Whether it's good or bad, nobody knows. The patients will be too dry on ventilator. So that is also equally bad. So we have to be very cautious about the FO, fluid overload. So there is a very good formula and very familiar formula of FO percentage introduced by Dr. Stuart Goldstein from Cincinnati. So the formula says total in liter minus total out in liter into 100 to express that in percentage. So that FO percentage, if we can calculate every 6 hourly, and we know whether what is the patient's trajectory of fluid status. We call it as a trajectory of fluid status. First 6 hours, it may be plus 1%. Second 6 hours, it may be plus 1%. Maybe plus 1 and plus 1, it is plus 2. And then plus 3, plus 4. If a patient moves up and above more than 2.5 to 5%, we have to be extremely careful. Usually, there are some institutes include bolus fluids in this FO percent calculation. There are some institutes don't include fluid bolus in this FO percent calculation. For a generic understanding, it is always better to include every fluid in and every fluid out. And see a cumulative fluid overload also to give you an idea what really happens. But most of the time, the decisions are based on 2 consecutive 6 hourly or over 24 hours FO percentage.
Okay, thank you, Dr. Sasidar. One more question. What is the access preference in your unit?
I would prefer a right IJV, ma'am, because the issue is either IJV or femoral. That may be the option. But the thing is, IJV beyond infancy, that being the biggest vein in the body, so you would be able to put a good size catheter, which is quite important for an extremely good flow and uninterrupted CVVHDF. Many times what happens is, we put a 7 French catheter, dialysis, the blood outflow is not very great, and there are huge amount of interruptions. Eventually what happens is, the effluent flow rate set is something close to 40, 45. The delivered effluent rate may be less than 20, 25 because of too much of downtime in 24 hours. So it is better to secure a good wide bore cannula. On the other hand, if a patient is on ECMO, and if the unit decides to put a separate cannula for CVVHDF or any kind of CRRT, there is no other go, we have to put a femoral vein. But subclavian, better to avoid, at least I don't use.
Okay, subclavian is not preferred in children, all of us agree with that. Okay, if Kalaivani, there are no more questions, I presume. I'm actually giving back to you for concluding remarks. If there are no more questions and no more comments.
On the whole, it was a wonderful session, sir, and it was a wonderful discussion on the whole. I think there are no comments per se. It goes without saying it was very good, very informative, and it was an enlightening talk by Dr. Jayati Sengupta, Dr. Sasidaran, and you being the moderating so well. Thank you so much, ma'am. I think we have exceeded our time as usual. Thank you so much, but we don't repent on that because it was a beautiful discussion.
Yeah, Kalaivani, there is one more question in the one more question is there in the box. To Sasidar, can you share the vascular catheter sizes?
Catheter sizes.
Vascular
Catheter
sizes.
Yeah. This is a very common question. It was quite unusual that I didn't get this question. So, so the thing is, actually, we need not remember anything or use a table. That is my very humble suggestion. Basically, what happens is less than 10 kg. Less than 10 kg, you may think of 7 French catheter, which is available. Metcom 7 French hemodialysis catheter is available. More than 10 kg, please never put 7 French catheter, because your blood flow rate, when you are keeping up and above 50 or 70, you may not be very comfortable at all. There is no point in that catheter. So it is better, even if you have to dilate and put a 8 French or 8 French catheter. And if the child is more than 25 kg, you go with the 10 French catheter. So this is as simple. If the child, there are now children admitted with 90 kg also, then you go with 11.5. So there is no need to, like mostly these questions are focused on newborn, small child, less than 10 kg. Can we use 2 6 French catheter? You can use 2 6 French catheter. But what I told about the effluent rate, target and deliver, that's what is going to happen in your unit. And your nephrologist will curse you. So please never do that.
I think we are done with the
Thank you. Yeah, all the questions over, and over to Kalaivani for conclusion. Yeah.
Thank you so much, Susan ma'am. Thank you, Sengupta ma'am. Thank you, Sasidaran sir. Thanks for the informative session. I too learned a lot of new things. Thank you so much, sir. Thank you so much, ma'am. Thanks for moderating the session so well. Thank you, ma'am.
Thank you. It is a great opportunity, and I learned quite a lot about tropical kidney disease. Thank you, Sengupta ma'am. It is a very elaborate and extensive presentation, and at least as an intensivist, I had quite a lot to learn from that. Thank you, ma'am.
Thank you so much. Yeah. The same here.
Thank you,
Thank you so much.
Thank you, ma'am.
Thanks to Kalaivani.
Bye.
Yeah, for carrying on. I hope best of luck for all the next coming sessions, and I'm sure they'll be equally good as it's been before.
Thank you so much, ma'am. Good night, ma'am.